Anterior shoulder instability with glenoid bone loss may be managed surgically with a bone block procedure. We describe arthroscopic distal tibial allograft bone augmentation using the posterior one-third of the distal tibia to restore the anterior ramp of the glenoid with cerclage fixation. Author disclosures are noted here. The distal tibia is secured and the allograft block depth, width, and length are marked. Typically, the graft is 25 mm long, 10 mm wide, and 10 mm deep. The graft orientation places the posterior-most aspect of the distal tibia at the anterior-most part of the glenoid when implanted, denoted by P, and the medial-most aspect of the distal tibia at the inferior-most portion of the glenoid when implanted, denoted by I. A sharp towel clamp may be used to stabilize the bone as an oscillating saw is used to cut the graft. A ruler is used to measure a 5 mm depth from the anterior articular surface. Two 1.6 mm guide wires are placed with the parallel drill guide without a flange 5 mm deep to the articular surface. The guide wires are over-drilled with a 3 mm cannulated drill and removed. Confirm the graft can fit through a 16 mm cannula that will be used for graft passage into the shoulder. The graft is soaked in PRP on the back table while shoulder arthroscopy and glenoid preparation is completed. The patient is positioned lateral with a 3-point shoulder distraction system. A large, slightly medialized, slightly superior posterior portal and anterior superior and mid-glenoid portals are used. Diagnostic arthroscopy is completed, noting anterior soft tissue injury, bone loss, and associated articular injury. A posterior capsulotomy can be made and is helpful to accommodate a transglenoid drill guide. If there is a large concurrent Hill-Sachs lesion, remplissage anchors may be placed at this time. While viewing from the anterior superior portal, a tissue elevator, shaver, and radiofrequency ablator are used to elevate the torn anterior labrum and capsule subperiosteally away from the anterior glenoid neck, medially from 2 to 6 o'clock on the glenoid clock face until the subscapularis muscle is visualized. A 5 mm transglenoid drill guide is placed parallel to the glenoid face with the hook seated at 3 o'clock on the glenoid clock face. Two 1.6 mm K-wires are placed through the double-barreled guide, one inferior and one superior. The wire depth is assessed via arthroscopic ruler and should be approximately 5 mm from the anterior glenoid articular surface. The transglenoid guide is removed and the wires are over-drilled with 3 mm cannulated drill bits. The top hat guide for a flip cutter is placed over the inferior cannulated drill bit and malleted gently into the posterior glenoid. The drill bit is then replaced with a flip cutter, which is advanced to the anterior glenoid and flipped to 13 mm. The goal is to remove as little anterior glenoid bone as possible while acquiring a completely flat, flush surface for graft contact. A fiber stick is placed through the top hat guide before it is removed, and the same sequence is completed for the superior glenoid tunnel. The mid-glenoid portal may be used as a viewing portal to compare the superior and inferior flip cutter depths and alter accordingly. The mid-glenoid portal is replaced with a 16 mm cannula for graft passage. The inferior and superior passing sutures from the glenoid tunnels are retrieved through the 16 mm cannula. After the cerclage sutures are passed through the inferior glenoid tunnel and grafted appropriately, the graft is introduced into the shoulder via the superior passing suture through the mid-glenoid cannula. Slack is removed sequentially from both the leading cerclage sutures and the trailing limbs that are through the inferior tunnel. Once the graft is seated in the desired position, the cerclage mechanism is deployed by introducing the cerclage suture into the contralateral knot and vice versa. The knots are tightened with a tensioner, a half hitch is thrown, it's retensioned and then completed with several more half hitches. Don't forget to tighten the remplissage sutures after completion of bone block fixation.